femur fractures. And the fracture site is almost identical from the tip of the greater trunk. Is it something related with bisphosphonates? Some people say yes, some people say no. And intraoperatively, you can see these kind of changes. A nice cut on the lateral cortex, the thickest portion of the femur, and with a short oblique fractures of the medial side. And when we go in there, remove part of the bone for HB examination, it's a hard, gritty bone. You know, the usual bone that you can grip up. So something that concerns us, because some of us use a lot of bisphosphonates for all our patients for many, many years, but it is a challenge for us. Is it because of oversuppression? As I say, some believe so, some don't. You can see a nice clear cut on the lateral side. It's something like a stress riser which has been there for a long time. And one day it just gives way, it breaks on the medial side. And this is the distal end. You can see a nice clear horizontal fracture line on the lateral at the thickest portion of the femur. So there's something, a concern that we bear in mind, that we keep. And because histological examinations show all these lines with polarized microscopic examinations and very minimal cellular activity. So a very potent anti-resorptive, is that beneficial or is it a potential problem? Because, as I say, we've been using bisphosphonate for the past 17 years for our patients. It's going to be a big challenge for us to tell our patients it is safe for you and how long it's supposed to be on the medicine. Therefore, it comes to the issue that a bone-forming agent, bone-forming drugs, and also something that does not bring the resorption down too much. In mechanism of action, as we know, the anti-resorptive are actually meant to prevent these kind of changes. Whereas if there's something bone-forming, hope that it can reverse the microarchitectures. As we mentioned earlier, not only the cancellous bone, but they also involve the cortical changes, so that we improve the microarchitectures of the bone, without worrying that we oversuppress the bone. Therefore, the current anti-resorptive treatments reduce bone loss. We all know that. That's the first thing we want to bring the bone resorption down. Therefore, reduce the fracture risk. But anti-resorptive agents are not able to form new bone and also restore your microarchitectures of the bone. And some patients still have high risk of getting fractures even after anti-resorptive, or might be because of oversuppression, because by the potent anti-resorptive. Therefore, bone-forming agents comes in. And bone-forming agents that we have now, the most potent, the one that we widely use is teriparatide. But they only reserve that for very elderly because of the cost, because of the inconvenience that you need injection every day, and it costs almost 2,000 ringgit a month. So we are looking for something that can actually cover all different age groups, particularly in the younger people, those 50s and early 60s. Rather than bring their resorption down too much, it's just something safer for them. At the same time, also safe for the elderly, and also allow them not only reducing the bone resorptions, but at the same time to allow bone forming. A patient 56 years old with one single fracture, what would be the best option for them? Or what would be the appropriate option for them? Comparing someone 84 years old, multiple fractures, severe hunchback, what would be the next option for them? For this group of patients, a pure anti-resorptive, is it good enough? Is it fast enough? You reduce the resorption, but wait for her to form a bone by herself. Is that good enough? As I say, is that fast enough? Therefore, it brings us back to this slide. This is very, as I say, it's a guide. It's very popular slides, and many of us adopt too. Of course, treatment individualized. We always emphasize the basic elements. We don't forget about the role of HRT for a younger individual. And we also recognize the importance of CERM, especially for those who stop HRT, younger individuals because they're not that potent sort of anti-absorptive. And we do not forget the role of bisphosphonates, no doubt. Data are very robust about fracture prevention, fracture reductions. And of course, teriparatide is widely used worldwide, but it's meant for a specific group of individuals. Therefore, we are looking for something that we can actually cover all different age, different severity, safer in terms of not over-suppressing the bone, at the same time forming bone for them. That's why I say this short talk is appetizing.